Now coming on to our fourth section, that is the distraction osteogenesis. As you know, we can use external fixators, that is uniplanar or multiplanar as well, and for other purposes as well. That is not only for deformity correction but also for distraction osteogenesis as well. In this section, we'll be briefly going what is cholestasis, chondrostasis, bone transport, and how we can correct bone deformities and joint contractures. Distraction osteogenesis is actually a form of tissue engineering founded on the principle of tension stress, which is a generation of new bone in response to the gradual increase in tension. If you see it over here, now this is will result in bone growth and bone transport over by use of distraction osteogenesis. This could be done by either this type of fixators or a laser-off method. Various applications of the principle, especially the laser-off, has been done, emphasizing minimal invasive surgery. There's actually through the bone only K-wire is going in, and early return to function because patient can be mobilized the very next day as well. So what is distraction osteogenesis or cholestasis? Actually, it can be used for limb lengthening or bone transport, filling large segmental defects in the bone. As for example, there normally if a large segmental defect is present, we can transport one segment towards the lower segment and cause the bone to grow over the proximal end of that segment. Then use of circular or unilateral external fixators. Usually circular are used for, but if it is for example small bones of hand, then we can use the unilateral as well. Distraction osteogenesis is actually all types of tissue is actually created in which the bone is actually grown over the period of time. This uses actually a low energy method for distraction osteogenesis, that the bone is actually there's a tension stress constantly with the bone, and this causes production of osteoprogenitor cells and osteoblasts so that the new bone formation takes place. So this process called as corticotomy, that is breaking of the bone. A normal bone cortex has to be partially divided. Why this is actually done? The breakup is actually complete by the use of osteocalasis. If we do not break the bone, we cannot actually ask the bone transport to regrow over it. Therefore, initially the corticotomy has to be done. Medullary blood supply and endosteum of the blood supply is really intact in this corticotomy, and periosteums can be incised. Bone is first initially drilled, that is made weaken by using drilling multiple holes, and then we can use an osteotome to actually completely divide the cortex of the bone. And then repairing of the periosteum is basically done so that the blood supply is restored. Therefore, once we have actually created a fracture in the bone, and by this we can use this segment to be transported along towards the lower level, and the new bone can grow over the proximal end of this segment. What is cholestasis? That is actually the first callus is seen at around the 3 to 4 weeks of the x-rays, and usually at this time there is a opaque material between the long bones. Distraction, if the distraction take is too fast of this callus, this could be a thin callus. If it's too slow, this could be a bulbous or worse or kind of a bulboid appearance of the callus. Usually it actually helps us to tell us whether we need to do the cholestasis or not. Other is actually once the desired length is reached, the second weight follows. Then regeneration column is to consolidate and harden. Once the soft callus is formed, we can actually make it wait for it to harden up to make a hard callus. One hard callus is formed, this is actually a mature bone, then we can do another corticotomy and do further osteogenesis or distraction osteogenesis. Weight bearing will help in the system consolidation of the callus. Physiotherapy is always required. The patient is actually immobile. Usually after this circular frame application, and the physiotherapy is done so that joint contractures are actually avoided. Then there is called as fibrous interzone, which usually disappears, which is usually formed when results in formation of fibrous tissue in non-union, but it gradually appears as the cholestasis proceeds. Then there is a term called as chondrodiastasis. This is, as you know, chondro is related to the cartilage and callus is related to bone. Therefore, this is actually increases the bone lengthening. The important point is there is no osteotomy which is required. Distraction rate is although slower. wide even the column is regeneration, it can be observed. If you see it over here, the new bone formation is taking place and growth plate is actually sealed afterwards. This is really happens in children. There is this chondrodystis is helpful. Now coming to the bone transport, sometimes when we're dealing with the problems, especially segmental bone fractures or bone loss in the mid diaphysis of the tibia, therefore usually it's away from the joint, then we may have to go for bone transport. Actually it's used for the filling segmental defects in the bone. Floating segment is actually created via corticotomy. If for example this was the segment which was lost, or this much bone gap is there, we can do a corticotomy over here, create a floating segment which can be transported towards lower bone area, and over the proximal end new bone can grow as it goes down towards this, and once it reaches towards the lower segment, the union can be achieved over here as well. So this is how bone transport is done, and external fixator is actually providing the stability, therefore shifts the load right from here towards this area, bypassing this segment, which is actually there is a segmental defect, and therefore helpful in the patient can be mobilized straight away, and segment transfers can still be done for corticotomy to the new docking site. There is called as bifocal compression distraction method, that is that the segment which has been actually created, a floating segment, is actually floated downwards to the new docking site where it is compressed, and from above it is actually distracted. So this makes it as a bifocal, that is compression and distraction happening at the same time. So bifocal compression distraction is actually the defect is closed by bringing the bone ends together. Corticotomy is performed at a different level, then the length is restored by cannulated, and limbs temporarily shortened, but eventually with the use of Lazaroff, the bone transport once is complete, the overall limb length is equal discrepancy actually disappears. So correcting the bone deformities in joint contractures. There could be angular deformities which can be corrected by multiple osteotomies or sudden tension of the soft sides. Other option is that we can perform the corticotomy, use a Lazaroff frame because it can correct the angular deformities, that is in AP and lateral plane, as well as in the rotational deformities as well. Therefore, the Lazaroff method is helpful that it can undertake large corrections as well, because it slowly corrects or gradually corrects the deformity. Therefore, the soft tissue damage is actually prevented. Otherwise, option why it is also helpful is that it's simultaneously dealing with the length of the bone, rotation, translation deformities as well. Therefore, the first correction is usually the length, then the rotation, and then the translation deformity. So soft tissue contractures can also be corrected. For example, in case of a resistant clubfoot deformity, if a child presents to you with, let's suppose, at age of 15 or 16 years with clubfoot which was actually not treated, or actually has a large callosities of the soft tissue as well, and with this kind of a rigid deformity, the one option is you can perform an orthodesis on one side, but if the patient has a bilateral clubfoot, you cannot have a bilateral ankle orthodesis. Therefore, you may have to use a Lazaroff method to first actually you do a surgery for soft tissue correction. Once the soft tissues correction is done, we can use this Lazaroff method to correct the bony problems as well, so that the plantigrade foot can be achieved. Initially, the gradual tension is applied to counter the soft tissue structures. Then external fixator in form of Lazaroff is applied actually to correct the bony deformity. Once altering the position of the ankle, subtalar, and the mid-tarsal joints, when this is done, this patient can be actually over the long period of time, or 1 month, 2 months, or 3 months, this can be corrected until the normal position is achieved. In this section, we have briefly discussed what is callosities, chondrodystis, or what is bone transport. Lazaroff has an advantage that it can also be used for segmental defects, especially after trauma or open fractures of the tibia, so that the bone transport can be done after there is massive bone loss. Therefore, Lazaroff is a kind of a dual-edged sword when we are talking about deformity correction post open fractures, or when we are dealing with open fractures overall. Keep watching sqadia.com. Thank you very much.